Hi everyone, it's Counseling 2500, Chapter 13, Addictions Counseling. One thing that we want to talk about when it comes to addictions is the fact that all people who work in counseling should be familiar with counseling with people who have addictions. The reason why is it's such a common behavior that happens when it comes to coping with stressors, with pain, and all that stuff. And we'll explain a little bit as we go along. But anyone who deals with counseling in the helping profession should probably be familiar with addictions. There's actually an entire class that's dedicated to this. So we're going to talk about basically being an introductory chapter on this in this class, but I hope that you go forward and actually take a class to really understand how addictions affects people's lives and how they use it as a coping mechanism. All right, addictions counseling is considered a specialization. Addiction itself is prevalent and pervasive concern on that no counselor can avoid. So even if you aren't a specialist, you still need to know about it. Again, what it says is prevalent, which means basically that it's happening, and pervasive, which means it's everywhere. Okay, all over the world. It's a common, unfortunate way of dealing with stressors. Chemicals or substances such as drug and alcohol has a physiological dependence. So that means that your body changes itself basically because of a reaction towards these drugs. So also that means that you can also build tolerance, which basically means you need more to feel the same effects as it did when you first started, let's say. And then of course withdrawal, if you don't do the drugs, your body's gonna go, where are the drugs that you've been feeding me this entire time? I need it. And you can go into a withdrawal phase in your body where your body is like, where are the drugs? Where are the drugs? Non-substance related addictions or behavioral addictions or process addictions are basically repetitions of impulsive behaviors that do not involve the self-administration of a psychoactive substance. So when it comes to this type of addiction here, which is a behavioral addiction, you actually don't have a drug that you're putting in your body, okay? It's more of a behavior that you do over and over again. The activity itself has become addictive, such as gambling, sex, overeating, video gaming, physical exercise, and skin tanning. And I think one that we haven't talked about when it comes to the book is probably social media addiction, right? All right, so let's talk a little bit about the foundations of addictions counseling. Substance use is common and often related to many other problems, which means that these are things that go along with it, right? People who are experiencing physical and mental illnesses, crime, unemployment, violence, family disruption, vehicular accidents and fatalities, financial strain and poverty, malnutrition, trauma, homelessness, and suicide. Let's hear some statistics now. In 2000, 46% of deaths were attributed to nicotine, alcohol, and illicit drug use, not attributed to disease, infection, or unintentional injuries. In other words, they were preventable. Okay. In 2005 to 2006, 24% of all suicides involved alcohol. In 2003 to 2009, 45% of all suicide attempts involved drugs and or alcohol in the U.S. Army soldiers. In 2001, 60 to 80% of persons in the criminal justice system have a substance use problem. So you can see right there, the numbers are kind of concerning, right? In 2014, they had the highest death from overdoses, with 61% of it from opioids, and that is oxycodone or fentanyl. So if you've heard about opioids, it really did happen in more recent times, and it actually killed a lot of people. And if you listen to the news now, I believe it just happened where the court ruled that the people who are makers of the opioid, oxycodone, have to shut down their stores or their factories. They're no longer allowed to make it, I believe. There's additional lawsuits and stuff because of the fact that they knew it was addictive and they were still pushing it to make money. Majority of people who use substances do not develop substance dependence, except for nicotine as the exception. So what that is saying is a lot of people use drugs, okay? But they don't let it go out of control or let the drugs control their lives. okay? Just think about the people who go to the bars. There are hundreds of thousands, if not millions of people who go out every Friday pre-COVID, where they go out and they drink and they have a good time and that's it, right? Or they'll do some cocaine or whatever it is, but that's it, right? They can still work, they can still have a happy, successful family, they have all the things that they want. Now we're talking about people who actually let, unfortunately, the addictions take over their lives, where they're thinking about, let's say, drinking or doing drugs while they're working or while they're taking care of their families, or maybe even letting their families and their work go to the side, and all they're really focusing is on drugs, right? So this is what we're talking about, the difference. There are a lot of people who are able to actually maintain drug use and be fine with it. All right, usage before 14 years old greatly increases the likelihood of dependence. So what that is saying is if you are under 14 and you start using drugs or drinking, then the circumstances or the statistics for you to use it in the future or become addicted to it is higher. There are also adverse childhood experiences, or ACE, that increases it by 3 to 4 times. And what we talk about when we talk about adverse childhood experiences are emotional, physical, and sexual abuse, if the child experiences those things. If they see parental discord or divorce, they have mental illness, substance abuse in the household. So if their parents or their siblings or someone in their family is addicted, having a battered mother, so basically a mom that's living with domestic violence, a survivor of domestic violence, or having a family member that has been incarcerated or have gone to prison. Presence of a psychiatric illness also greatly enhances problematic substance use. And the reason, and that can make sense, is, if there's pain that's going on, you want to do something to dull those pain. So by using another thing to dull that pain, which is drugs, then you don't feel as much. But then you become dependent on this drug to make those feelings go away, right? So it's not a healthiest way of doing it. Comorbidity is a key word, a popular word when we talk about addiction. So comorbidity means having a substance use disorder and a mental illness at the same time. Okay, so you might see comorbidity happening a lot of the time with people who are homeless with mental health, right? Mental illness. In 2010, 43% of all clients enrolled in substance abuse treatments were diagnosed with a co-occurring mental health disorder. So they said that about 47% said that they also had schizophrenia, 56% said they had bipolar disorder, and 84% had antisocial personality disorder. Cross-training is basically graduate training in mental health counseling and addictions counseling. So if you guys choose to go into grad school to get your master's, definitely you will be cross-trained. You will understand all the medical issues that happen to your body when you do drugs, and you also have a mental illness. America sees substance abuse and alcohol addictions as a choice. So it's almost like a moral thing, right? So a lot of people you'll hear say, well, you chose to drink, why don't you just stop drinking? And then you don't have that problem. But it's actually much more complicated than just saying, well, you could have just stopped drinking, because it's a choice, right? As we have seen in studies, some people have genetic factors that come along with it, or again, mental issues or pain. People use it to dull, or maybe it's societal constructs such as, men should not cry, they should not express emotion, and so instead they deal with it through drinking or doing drugs or whatever to cope with that, the inability or being not allowed by society to express these feelings that they want to express. Addictions counseling, prevention, and intervention. The most common reasons: lack of health care coverage, inability to afford the cost of treatment. So those are two reasons why people don't seek out counseling for addictions. Lack of readiness to stop using is another one. Of course, you're not ready. You don't know that you have an addiction, let's say. Believe that the problem can be managed without treatment. So of course, you can say, oh, it's okay, I can deal with it. It's not that big of a problem, I can handle it. Or lack of transportation or other inconvenience, such as no childcare to go seek counseling, and perceptions of negative repercussions. So losing a job or having stigma, someone knowing that you are addicted to a drug, for some people that becomes a negative, and they might be embarrassed or whatever, and so then they don't seek out the help. Counselors working with this population should believe that it is preventable and treatable. Okay. See addiction as not a moral failure. See addiction as a maladaptive behavior, not a defect. So it's just a bad choice, right? And we're going to try and help our clients living through addiction to make better choices and behave in a better way when stressors come into their lives. There's also evidence-based practices in addiction counseling, and I'm sure you're aware of this, and we'll be talking about a couple of the really well-known and really well-accepted evidence-based practices in addiction. There are 4 groupings of effective treatment. So the first part is motivational interviewing and motivational enhancement therapy. They're very similar. And I believe you've learned this when you were taking Counseling 2000 and the Intro to Rehab Foundations, I believe, or Intro to Rehab. So I'm not going to go further in here. However, if you are interested in talking about motivational interviewing, I definitely recommend that you go and read the book. The authors who created motivational interviewing, it's just the foundation book. You need to just read it. It's really helpful. There's no other better real book, I think, besides that motivational interviewing book. There's also 12-step facilitation treatment, also known as just 12-step. 3 is cognitive behavioral treatments and behavioral family counseling, so involving the family into the process of addiction. And 4 is contingency management and community reinforcement. So that is, if you do this, then you get rewarded for this. That's what a contingency is. You know, if you do this, you get that, right? So let's explore these as we go along in the next couple of slides. All right, let's talk about motivational interviewing, or MI. Method of communication intended to help clients mobilize their own internal resources for change. So what that is basically saying is, it's just a fancy way of saying, is sometimes people who are addicted to drugs or alcohol don't realize that they're addicted to drugs or alcohol. So by doing motivational interviewing, we're hoping that they actually realize it during their talking, during that time. It's a structured way of talking. For them to basically go, oh, maybe I actually do have something going on that's not good, right? It involves respectful and non-judgmental approach for people who do not think that they need to change, are ambivalent about changing, or are preparing to change. Again, so we're talking about a lack of self-awareness when it comes to addiction at this moment, but to hopefully bring that out by letting them realize it themselves. Because, you know, sometimes, you know, when you see someone who's drinking, you're like, you shouldn't drink, it's bad for you. They're gonna go, duh, I already know, right? So that's not really going to help a person motivate them to stop drinking. So instead, it's for them to realize it themselves is when they might want to then change. It is a therapeutic style, not a technique. Uses fundamental listening and attending skills in a strategic, directive, or purposeful manner to guide clients through their own process of change. Again, so as you can see, it's about practicing and learning how to talk to someone in a way where they realize it themselves. Okay, it's about not you telling them from your own observations. It's talking to them and letting them figure it out for themselves. And it's a really effective way. It was created initially for addictions, but it's been actually now used in many other areas as well. But motivational interviewing, if you're interested in addictions counseling, is one of those skill sets that you need to practice and be aware of. In motivational interviewing, there is a thing called OARS, O-A-R-S. Okay, and it stands for 4 things. O stands for open-ended questions, which are basically questions that when you ask your client, they're going to have to talk a little bit more than just a yes or no answer. A yes or no or one-worded answer is usually called a closed-ended question. An open-ended question would be something like, hey, what did you do for the weekend? You know, and hopefully they'll talk a little bit more, right? So A stands for providing sincere affirmations. Sincere affirmations basically mean you being authentic, right? And you being really honest when the person is saying something is that you agree with them because you believe what they're saying. And then the R stands for extending empathetic reflections. So when you're listening to them talk, you're able to reflect back or state back to them exactly how they're feeling at that time. So they might be telling a story and then they start to cry, and then you can say, it shows me that this experience that you're telling me about is showing me that you're feeling sad, right? That means you're reflecting the correct thing that they are putting out, right? It could be frustration if they were yelling and you said you feel very frustrated. I can see that right now, right? And that would be empathetic reflection. And the S stands for offering a summary of content. Again, summary is basically at the end, is you're going to retell kind of what has happened overall so far in this session. Reflective listening is most important. Reflections are statements, not questions that make a guess about what the client is thinking or feeling. So when you reflect, you need to know exactly what kind of emotions they are showing you right then and there, and you need to put a word to it. So you can say, you are frustrated right now. Right? And I actually do this quite a lot because that validates that person's feelings at that moment, right? If they're saying all these things and you tell them, this is how I see you're feeling that way, they're like, yeah, that is how I'm feeling. There's a connection, right? And then hopefully that way we can move forward. Now let's talk about 12-step facilitation treatment, or 12-step, or TSF. So TSF is designed to help clients find and participate in Alcoholics Anonymous, also known as AA. There's 12-step fellowship meetings. It's internalized and endorses the philosophy of AA, more likely to achieve and maintain abstinence 1 year after treatment over motivational enhancement therapy and cognitive behavioral therapy. Okay, so what that is saying is 12-step is kind of designed to go along with AA because it states the beliefs that AA talks about. So TSF, or 12-step, is a treatment conducted by a professional counselor that can be delivered in individual sessions. So it's one-on-one with people. Belief is that alcoholism is a progressive illness that affects your body, your mind, and your spirit. Alcoholism is characterized by a loss of control over drinking that can result in death if left untreated. And the only effective remedy is total abstinence from alcohol. Okay, so you'll see these two things together. I will warn you, right? There's 12 steps. You need to recognize when your clients are ready to go from one step to the other. Okay, do not move along really fast. That's not the point of going through all 12 steps. Okay, is to meet your client where they need to be. Right? And we're talking about respect and understanding their pace and stuff like that. Because again, addiction is a very a strong behavior to let go of. Here are the websites. The first one's Alcoholics Anonymous, so you can find a little bit more information. It's www.aa.org. And then the other one is www.samhsa.gov/treatment, and it's a locator. Okay, so please visit these two so that you're familiar with it. So if you do end up working with clients, you know that these are two resources when it comes to addictions that might be very helpful for your clients. 12-step counselors review the 12 steps and the 12 traditions of AA, discusses protocols for AA meetings, and this is something that usually if you do take an addictions class is that your professors will probably ask you to attend some open meetings for AA. Open meetings basically means that anyone can go in there. You don't have to be someone who has addictions to go there. Okay, then there are closed-ended groups as well, but open-ended ones you are able to, or open ones, open groups, you can actually attend and it'll be fine. So when you do go to an AA before you recommend it to your clients, you'll understand that it helps prepare clients to know what to expect at meetings, reviews with clients their experiences at recent AA meetings, encourages clients to sample a variety of meetings until they can find a fellowship to call home. So again, just like counselors, if you don't like one, you can go to another one to see if you like it a little bit more, right? I'll give you an example. I had a friend who is gay, and so he went to one in WeHo, or West Hollywood, and he felt a lot better there than where he was when he was where he's living, which is in the suburbs. Consistent again with the AA philosophy. And 12-step promotes total abstinence, spiritual development, and long-term recovery. And another thing that I will tell you is that it feels very religious when you go there, right? But you must understand that when you do it, and you might not, let's say, believe in, let's say, the Bible or anything like that, to realize what spiritual development means to you, okay? It doesn't necessarily have to be the Bible, although they might emphasize that because it was created this way. Okay, let's talk about cognitive behavioral treatments and behavioral family counseling. So this is something where there are 4 things that we want to cover immediately, which is identifying the stimuli associated with use or triggers for using through daily self-monitoring. So that means, as you know, in cognitive behavioral therapy, it's a lot of attention to details, right? A lot of recording of information. So one thing is you might write down all the things that you do each day, and then we'll start to find out where there's certain things that might trigger you to want to use drugs, right? So maybe it's you pass by the bar that you always go to when you go home from work, and you usually just stop in there and you start drinking, right? So that means maybe trying to find a different way of getting home. Number two, learning and practicing specific coping skills to avoid triggers and reduce cravings. And that means mindfulness, right? It's paying attention to what's going on around you so that you don't let those things overwhelm you. Okay. Three, identifying the costs and benefits of using, as well as the costs and benefits of not using. So this is basically creating a list, pros and cons, right? When I drink, these are the good things that happen. When I drink, these are the bad things that happen. Or when I don't drink, these are the good things that happen or bad things that happen. And we hope that the client will notice and realize that when they don't drink, their lives are actually a lot better. And four, learning to communicate more effectively with loved ones, and that will be conflict resolution skills. Learning how to talk to people is really difficult for some people, right? Even for me, sometimes I'm like, I'm so uncomfortable in this conversation. I don't really know how to go, where do we go from here? And so learning how to communicate, learning how to have your client learn how to communicate with their partners and their children who are witnessing them go through addictions is really important. One report suggests that when someone first enters treatment, an average of 15.6 years has elapsed since the first use. So that's a long time of doing this type of behavior to try to stop, right? So what that is saying again is when people finally go into, let's say, addictions treatment, they've already experienced about 15 years, over 15 years of addiction, okay? So imagine trying to break something that's 15 years old. It's just going to be very difficult and challenging for some. Addictive behaviors are firmly established during this time period, obviously, when you meet them. And scare tactics, such as scared straight programs, actually cause more harm than good. I don't know if you've ever seen those shows where like they put little kids in prison, and scare them like this is how it is. Get the scariest prisoners to come in and scare them and stuff like that. It actually statistically it shows that it's not as effective as just typical treatment that we were talking about before. Involving family members in the prevention and treatment efforts has become a standard practice now, right? Because again, our problems most of the time are not alone. Maybe it's things that happen in the family that causes a person to drink or not drink. So we want to involve it so that we understand how to make the entire environment healthy for this person. So we're talking about engaging the partner or family members in a plan for systemic change. Maybe some of the family members can drink without getting addicted. So to respect the family member that has gone through addiction or is going through addiction right now, maybe they need to stop drinking as well, or don't make it so visible, right? Clarifying and reinforcing family roles and responsibilities, achieving and maintaining abstinence, and improve relational dynamics and satisfaction. So if there are family problems, let's go to therapy and talk it out and try to figure out how to make our family happier so that no one feels like they need to drink to cope with, let's say, the stressors of that family. Here are some more behavioral approaches: establishing and abiding by written recovery contracts among family members that promote substance-free and other healthy behaviors, such as attending self-help support groups together. So we're going to say we are a family. We want to work together to try to resolve this, right? Don't let the person who's addicted do it all on their own, because it does affect everyone, right? But that takes a commitment. That means it's taking time out of everyone's lives to go and support them. But statistics show that if the family does it together, it's going to be helpful. Improving daily interactions, including participating in recreational activities. So maybe every weekend, instead of drinking or going to the bar, the family will go to the park or do activities like, do errands together or whatever to prevent them from thinking about or going out to the club and to drink. Increasing reciprocal positive exchanges basically means doing things that are good for each other. teaching constructive communication and problem solving skills, and expanding a support network beyond the family unit. So maybe going out into other networks like support groups or whatever together so that we can make sure that everyone is together in the family. Now let's talk about contingency management and community reinforcement approach. So again, it's still part of the cognitive behavioral treatment based on operant conditioning principles such as positive and negative reinforcement. So that means is to increase a desired behavior, let's say, we're going to reward them with things that they like or take away things that they don't like so that they can continue doing it. So here's an example would be, let's say they really love candy, right? So if they stop drinking, let's say each week they get a bar of candy, right? Because they love candy. Or taking away something they don't like, such as, let's say that the person really hates doing the dishes. So every week that they don't drink, they don't have to do the dishes. Does that make sense? So negative reinforcement is not punishment. It's actually taking something they don't like away so that they continue to reach that desired effect. So contingency management, or CM, has tangible reinforcements. Tangible basically means things that you can touch or sense. So that would be vouchers or food or cash or candy or whatever. Community reinforcement approach, CRA, is environmental or natural reinforcers. So this is withdrawal of spousal affection. So if you drink, let's say the partner will say, we're not going to have sex, right? Or time spent with the children. I know that sounds really horrible or weird, but that's actually very true. Like, you know, if you do these things, the partner might not show affection with that person. To show them, you know, that is kind of like a punishment right there, right? Because you are actually making them feel bad about what they have done, hoping that this will reduce their behaviors that way. All right, common practices and formats in addiction counseling. Recommending that clients attend and become involved in AA or other self-help support group meetings. AA is pretty common when it comes to addictions, especially alcoholics or Alcoholics Anonymous, but there are also NA, Narcotics Anonymous, Sex Anonymous, and a bunch of other things as well. Consulting with the client's referral source as well as collateral, such as family members or friend. So maybe the counselor is also going to talk to the family members and understand where they're coming from, what their perspective is on the situation, and periodically screening for biological markers. So that is just looking for signs of addiction. Okay. AA started in 1935 in Akron, Ohio. This is just a little bit of a history. The largest self-help group in the world, and it's free, widely available, voluntary, anonymity and confidentiality are emphasized, but again, it's not guaranteed, right? Because as a group, if it's one-on-one, the therapist who is professional and who is trained will keep everything confidential, but when it's a group, we cannot control all the people who attend, right? Members have shared experiences and groups are self-governing. Groups remain the most common format of treatment for addictions because it's practical, which basically means it's easy to do, and it's economical, which basically means that it's affordable or cheap. Learning new skills, such as interpersonal skills, is important during this time period, basically communicating with other people, reestablishing connections with others, and receiving feedback from peers and not authorities, like a counselor. So they're actually seeing other people who've gone through addictions as well and how they react to them, right? As opposed to, let's say, a counselor or someone who they feel like has more power and they know that they're going to be yelled at or scolded or something like that. But when it's being told by someone who is their equal, it might be much more powerful. Diversity and advocacy in addictions counseling. So ethnic and racial diversity is really important when it comes to addictions. In the book, it talks about African Americans, Asian Americans, Latino Americans, Native Americans, and Caucasian Americans. I'm not going to talk about it here because they're basically just statistics that will continually change, but I do want you to look at the book to see exactly what the statistics are at this moment and find out which ethnicities are considered having the most amount of addictions to which ones have the least amount. But it's just not those numbers. I also want you to start thinking why those certain groups have higher addiction rates than other groups. Okay? You know what I'm talking about? Social justice warriors, right? So that's something that I want you guys to look at. Treatment considerations when it comes to diversity and advocacy in addiction counseling is minority populations experience a higher rate of alcohol-related problems compared to Caucasians. Minorities have more complex treatment needs because of the culture that they have, and because a lot of the times those types of treatment plans are created for people who are Caucasian. They don't understand or they don't put into consideration cultural differences, right? Influences are limited employment opportunities for people who have addictions, along with their ethnicity, and of course, illiteracy or low educational levels. So if they don't have or are able to access the information when they get it, that's not going to help them either, right? If they can't read, they're not going to be able to read the pamphlet that was given about addictions. And of course, poverty and other unhealthy environmental conditions also will maybe, right, increase the level of addictions for some cultures. Along with ethnicity differences, we're also talking about specific populations such as adolescents, women, older adults, LGBTQIA, military persons and veterans, people with disabilities, and people who are homeless. And we're going to cover each of those in the next couple of slides. All right, adolescents in 2015, 64% of 12th graders drink. Did you drink when you were in the 12th grade? 1 in 17 12th graders smoked marijuana every day. Are you one of those kids? Or were you one of those kids in 2015? Rates of marijuana has increased, and that makes sense, right? Because marijuana is now more available than they were before. And so that's something that, it makes sense, right? And then, of course, influenced by peers and family. So peer pressure, we hear about that when we were younger, right? Everyone else is doing it, then you should too, right? And so that causes people to experiment and try it out. Some become addicted, some love it, and some use it only, moderately, and some don't use it at all because they don't like it. Women. White women, 55 to 64, accidental opioid overdose deaths is the highest by age and gender recently. Okay, so this is why you'll hear, and this is not surprising because it affects Caucasian people, that's in the news more often, that there's an opioid issue going on, right? If it was a minority, unfortunately, probably a lot of people would not talk about it or try to deal with it. But because a lot of people who are Caucasian, and again, we're not blaming Caucasian people, it's just, again, we're talking about privilege and stuff like that, is people tend to be more concerned in society. The lawmakers, the rule makers are more concerned because of that. But of course, there's also other reasons why as well. Women are less likely to seek out help than men when it comes to addiction, increases the risk of mental and physical health problems, and increases the likelihood that a woman will be a victim of a violent crime or sexual assault. When they're addicted, they're much more vulnerable, right, to being raped, to being abused. And so that's something that you need to put in consideration as well. Women consume smaller amounts of alcohol than men, advance much more rapidly to alcohol dependence. So that's something that is like, a telescope, basically. Imagine this thing that basically makes things closer than they appear, right? So again, the same thing happens with women, is that they don't need as much and they can get equally as drunk as let's say a man. Okay, obviously that's not true for every woman or every man. Some men get drunker and faster than some women do, right? But these are like the statistics because of body weight and stuff like that. Also, with women, their children could have fetal alcohol syndrome. Okay, and then there's also child abuse or neglect when it comes to addictions involved in the family. There's also multiple barriers such as economic hardship, transportation, family responsibilities, and less likely to seek treatment for substance use, like we talked about before. Now let's talk about the LGBTQIA population. The book really does talk about LGBT because books are a little bit older than 2020, which is where we are now. So I wanted to add the QIA, which stands for queer, intersex, and asexual. All right, so when it comes to LGBTQIA people, difficult to ascertain numbers. Research is usually done in gay bars. So we really don't know all the numbers because the place where people do research on the LGBT population is gay bars. Gay bars are usually populated by men, right? So then the numbers are going to be a little off. So what we're saying is we don't necessarily can trust everything when it comes to LGBTQIA because there's not enough research out there yet. But hopefully we will have it as we go along. All right, LGBT typically use substance more often than in the general population. We do know that. So statistically, why would you think that people who are LGBTQIA use drugs more often than people who are not. I just want you to start thinking about these things. All right, when it comes to gay men, increased use of inhalants, hallucinogens, stimulants, sedatives, marijuana, and tranquilizers. Think about why they're using everything, right? Lesbians, higher use of alcohol. Influences. The coming out process may be one reason why people start drinking or doing drugs. Family of origin and relationship issues. As we know, a lot of teenagers, when they're younger who are LGBTQIA, if they come out, their parents actually do kick them out and make them homeless or disown them. So that might be another reason why. Legal problems and discrimination. That makes sense. And substances as socializing agents, which basically means doing drugs to be able to socialize with other people, right? Because you are scared, you're worried, or whatever. So, have you ever heard someone saying, getting a drink for bravery, right? I forgot what the phrase is, but, to be brave is to, take a couple of drinks. So then, liquid strength, liquid courage. That's what it's called. Booze is liquid courage, right? Because then you feel like you're going to be able to do the things that you want. Now let's talk about veterans and military persons. Prescription drugs use and heavy alcohol use in this population. 7% of veterans experience serious psychological distress, and veterans with $20,000 or less, if that's how much money they have a year, were more likely to experience serious psychological distress, substance use disorders, or co-occurring disorders, like we talked about before. Older adults goes unidentified and unaddressed because people don't necessarily think about older people being addicted to drugs or alcohol. Baby boomers have more liberal attitudes to drug use and prescription drugs because they were younger during the time when the revolution for drugs, like people were smoking weed and all that other stuff, and it was acceptable. So for baby boomers, it's okay if you drink or do drugs or whatever. It's fine. So that might also increase the amount of usage for this population. Social changes such as retirement, death, or peers may be the reasons why they start using drugs. Physical changes such as the metabolism, their health conditions, and that's why they start to use drugs as well. And I want you to remember when we talk about drug and addiction, we're not just talking about weed and alcohol and cocaine and meth. We're also talking about prescription drugs, painkillers, like opioids, like we were talking about before. People are addicted to painkillers as well, right? Amongst other prescription type drugs. Now let's talk about people with disabilities. There's physical, sensory, cognitive, and affective mood and feeling. People who are experiencing all those different types of challenges or barriers, right? Co-occurring disability and substance use. Remember we talked about comorbidity. Higher rates of substance use disorder, including veterans and older adults, less likely to initiate or complete treatment because of their disability. So again, when we say substance use is really high in this population, we're also including people who are older and people who are veterans who also have disabilities along with, those other things that we were talking about before. So it's a massive population. Remember, disabilities or people with disabilities is one of the hugest minority groups there are because disabilities exist in every culture and every type of person, basically, right? So there's going to cover a lot more people. People who are homeless. Those are people who are youths, women, and people who have mental illness. Obviously, there's men as well, but we're talking about these specific populations. Use of substances usually prevent them from receiving services or being eligible where treatment is offered. So I know it sounds kind of silly, but there are certain places that are home, like let's say homeless housing, where if you're doing drugs, we cannot give you a place to stay. So it becomes such a strange issue because people can't just stop using drugs, right? So that they can get these housing. So it needs to be approached in a different way. Low priority when it comes to drug use over things such as safety, shelter, and feeding her children, let's say, right? Those things are more important, so they're going to focus on those things over treatment of drug use. Now let's talk about evaluating methods in addictions counseling. Psychometric instruments are frequently used by counselors to help them determine whether or not a substance use exists, a substance use problem exists, and to what degree. So basically the first step that we're talking about is screening. Screening is the first step. Screening tools basically set of brief questions asked by the counselor during a conversation, hand-recorded or computer-based questionnaires, and biological measures such as a breathalyzer, hair test, urine test, or blood test to determine whether or not they have it. So this is just to determine whether or not they have a drug addiction problem, right? We're not talking about how to help them or understand why they're doing it. Screening basically means we want to make sure that they have this so that they can move on to the next step of getting help. Once through with the screening, recommended further evaluation, much more comprehensive evaluations to really understand why now that they're using or whatever, their histories, their medical histories, whatever it is. Determine that further evaluation is unnecessary at this time. So for some people, that's all they need, right? And then administer the screening again at a later time, again to see what's going on again. So here are 5 screening tools that the book recommends. The first one is called CAGE, C-A-G-E, and that stands for, have you ever felt the need to cut down on your drinking? So C stands for cut, like cutting down. Did you ever think about maybe you should stop drinking as much, let's say? Second, for the A is, have you ever felt annoyed by someone criticizing your drinking? So feeling annoyed when someone says, oh, you're drinking a lot. You're like, oh, whatever, I don't care. It's not me, it's you, right? G stands for, have you ever felt bad or guilty about your drinking? So feeling guilty about drinking, like did you do something that hurt someone else or whatever, and you felt guilt. And then E stands for, have you ever had a drink first thing in the morning to steady your nerves and get rid of a hangover, which means it's an eye opener, right? So CAGE stands for cut, annoyed, guilty, and eye opener. So in the morning when you wake up, the first thing you need is a drink. Is that something, right? And if you say yes, you need to explore your drinking behaviors. If 2 to 3 of these things you say yes, likely that alcohol use is a problem. And if you say yes to all 4, further evaluation for alcohol dependence needs to be conducted. See? So we're screening to see whether or not this person potentially has it, and then we go further. TWEAK is another one that's more effective than CAGE. So basically, CAGE was 4 letters. TWEAK is 5 letters, so it's a little bit more comprehensive. So TWEAK stands for tolerance. How many drinks can you hold, or how many drinks can you drink before you black out, let's say. Worried. Have close friends or relatives worried or complained about your drinking in the past year? E stands for eye opener, just like we said before. Do you sometimes take a drink in the morning when you first get up? Amnesia. Has a friend or family member remember ever telling you about things that you did while you were drinking that you could not remember, right? Like you can't remember what you did when you were drinking. And then CUT, which is spelled with a C, but they say spell it with a K, is do you sometimes feel the need to cut down on your drinking? So again, yes, in any of these processes, then we would need to get further assessments. MAS stands for the Michigan Alcohol Screening Test, has 24 items of yes or no responses, and not helpful for detecting less severe alcohol problems. It's more for the severe ones. There's also the SASI, which stands for Substance Abuse Subtle Screening Inventory. It's about 15 minutes. Talks about high or low probability of substance dependence disorder, but it's not as good as the other screeners. But I actually have seen the SASI over a lot of the other ones out there in the world. Okay. Then there's also AUDIT. AUDIT stands for Alcohol Use Disorder Identification Test. It's 10 questions, 3 that are on accessing alcohol consumption, 4 on symptoms of alcohol dependence, and 3 inquires about alcohol-related problems. So now that we've gone through the screener, now we're going to go into assessments. Determine the degree or extent of the substance use problem. Is there a diagnosable disorder present when it comes to now meeting with this person and talking to them in more detail? Understand the multiple facets of a client's substance use, such as negative consequences, such as a relationship problem, legal problems, employment issues, physical or mental health concerns. So now we're starting to examine the person's life, right, in a whole, in a like an overall holistic approach, right? We're looking at all the different things that may cause drinking or associate with it, or as a trigger or a reaction to. There is the Addiction Severity Index, which is the ASI. It's 1 hour long structured interview. Again, structured interview basically means there's a questionnaire that the person will read through. They're not making up questions as they go along. It's very specific questions. And there are 161 items or 161 questions for this person. And again, if you want to know more, there's also the Assessing Alcohol Problems, a Clinician's Guide for Clinicians and Researcher. It talks about how to introduce screening and assessment instruments to clients, appropriate timing of evaluation, and ways to provide clients with feedback from evaluation measures. Hopefully this will be really helpful for you guys as an intro to addictions and to be aware of the things that are going on and how common addictions is when dealing with people who are seeking help.